Thank you very much, and also thank you for the organising committee for inviting me here. As you'll see from the title, if you actually thought you were going to get a talk about dementia and the details of it in 15 minutes, that was going to be a long and complicated ask. And what I'm going to try and do is trying to connect up, I suppose, what has been a really fascinating discussion about ageing in general and perhaps what's happening to us as time goes by, and try and connect that to the thinking we've got about impaired practitioners, and think perhaps about impaired patients. Because I think as Nick started the discussion today, this morning, saying that we're in the middle of a revolution, we could be, if we better make sure we know what's going on. Well, we are in the middle of the ageing revolution, and I think that we need to be aware that there's a change in our patient population, and my work recently has been around organisational change in hospitals, particularly in relation to cognitive impairment and the impact on risk in hospitals. And so what I'd like to do is to talk about ageing and just very briefly then the demographic of dementia and the impact that might have on our hospitals, talk about cognitive impairment in hospitals and the information we now know about dementia in hospitals and the risks associated with that, and then talk about the Dementia Care in Hospitals program, which is now a national program which is being rolled out for a further evaluation. So I guess it was the Egyptians I thought had a good idea. I think this is a bit of the Egyptians. We started with pyramids, and like the Egyptian kings themselves, they end up in sarcophaguses, and that's where we are at the moment. And this is the reality of our demographic, and maybe that'll get changed if the work for David's has an effect, which I'm sure it will. And the impact of this demographic change is actually on our own hospitals, and so I think we have to be very aware that when we look at the increase in separations of older people, they're rapidly changing, and I think it's important to put that in the context of what the national increase in separations is. It's 4.7% in that same period, and in the older age groups, of course, this is rapidly increasing. So when we actually work in hospitals and our staff are saying there's a lot more older people, well, they're right. Because they stay. So then how does that translate in dementia? And for those in the field, they don't have to see this data to know, and most of us in the community don't need to see this data to know. But if we look at, we're in the middle of this now, 2011 to 2020, there'll be about a 34% increase in the number of people with dementia in Australia in that period of time. And different states have different rates, and that reflects how old those states are now or how old they were in 2011. So the younger states are going to have a more rapid or a larger percentage change. The younger states will have a larger percentage change than the older states. So if we understand we're in an ageing society, dementia is, as Kathy pointed out, is the major risk factor for dementia is age. It's not surprising that we'll see more people with dementia, and we will see an increasing number of older people in hospitals. So how does that translate to our hospital population? Well, in hospitals then, there is now data that's emerged. This is work by Travis and Len Gray and others in Queensland using the InterRI as their measure. They found a population, about 30% of the population over the age of 70 in acute medical and surgical wards had either dementia or delirium. In our hands, using validated screening tests for cognitive impairment, not formally making a diagnosis of dementia or delirium, our data suggests that about 30% of all adults in acute general surgical and medical beds have cognitive impairment. And we've also done this sort of work in the private sector as well, and the figure was about 27%, and that was across Cabrini Malvern, Cabrini Brighton and St John of God in Bendigo. And in fact, I can tell you now that we've got our baseline data from our national rollout, and the similar sorts of figures are emerging in South Australia and also in Canberra. And that's using scales such as the mini-cog, the AMTS, etc. So if we've got a large number of older people and they're populating our hospitals, and cognitive impairment is now common in those hospitals, what does that mean for those patients? Well, If I was a businessman or a CEO, this is what would worry me the most, is that the average length of stay is 3.5 times longer when dementia is a principal diagnosis and 2.5 times longer when it's a secondary diagnosis. And by far and away, and I'll mention this later, but most people don't come into hospital because they have dementia. They come in because they have something else and they bring it along in their toolkit with them. And I think it's also important to note that over the last 5 years, as geriatricians, I think very successfully, we've driven the average length of stay down very successfully in acute hospitals by 24% over the last 5 years, whereas the national average decline is only 6%. So if we think that just being smarter and getting older people out of hospitals because we'll discharge plan is going to solve the problem, I think we've got to think about that again. We have to actually be smarter about how we're caring for older people in hospitals if we're going to drive the risk down. And this population, which probably represents 30% in our acute general surgical wards, are expensive and take extra time. And some of that time may be because staff find it really hard to look after these people. And this is data we've collected in our various evaluations across the 22 sites that we've been working in, but about 80 to 90% of clinical staff perceive it's difficult working with people with cognitive impairment. So they're not nice people to work with, and if you're not a very nice person, you generally don't get as much attention as if you're a nice person. So, and it is a source of considerable burden to staff, and in an environment where there's already high levels of turnover, we want to try and empower staff so they feel more comfortable managing people with cognitive impairment. So we know people with cognitive impairment in hospitals are costly, and we know that staff find it difficult and it causes burnout. But what we also now know, courtesy of some very excellent work done through the Hospital Dementia Services Study by Brian Draper and his team and the Australian Institute of Health and Welfare, is that in fact if we look at a suite of what are called preventable hospital-acquired complications, then if we match a population in medical or surgical wards for comorbidity using the Charleston Comorbidity Index and age, and just separate them for dementia or no dementia, then the likelihood of getting a urinary tract infection in a surgical ward is almost 3 times higher than the non-dementia population, and about 1.7 times higher in a medical ward. And pressure areas are increased, pneumonia is increased, and obviously we knew that delirium was going to be higher. So this is a very important piece of data because we don't quite understand why, but it's quite clear. In these preventable hospital acquired complications are a well-validated suite of about 12 complications that are nursing sensitive. In other words, if you change nursing ratios or you increase the amount of nursing involvement or education, you can change the outcome. And so here we've got a suite of adverse events that if we actually intervene at a nursing level, we may in fact reduce those adverse events. And I guess my hypothesis is that if we don't know we're dealing with 30% of the population have got cognitive impairment, then how do we actually support them? And the challenge around this is that cognitive impairment is subtle. I don't know how many can actually read this, but the bottom line of this is the mini mental state examination score, which is our standard screening instrument at Ballarat Health Services. So everyone over the age of 65 who comes into Ballarat Health Services is screened for cognitive impairment based on the MMSE and clock face. And this man had quite significant dysexecutive syndrome. His score was 27 out of 30, but his clock face was clearly abnormal. And that's quite common in delirium and other vascular events. And he's actually had some visuospatial abnormalities. But this set of clock faces comes from the ACT. So these were clock faces that our project officer collected where the nursing staff were surprised. They're using the AMT4, which is 4 simple questions, but I've insisted that we add the clock face into this set of suites for our cognitive screening. And the AMT4 was normal, was 4, but these are clock face drawings. And so it's quite difficult to identify this population unless you actively screen for it. The usual nursing chit-chat or the ward round discussion is not going to identify a patient with cognitive impairment on the ward. And that makes it very difficult sometimes without screening. But screening is easy. How hard is it to give a patient a piece of paper and a pen and ask them to draw a clock face? You don't have to be English-speaking background to draw a clock face. You just have to get the patient to do it. And it does mean that there's something the patient has actually done, which is also actually a very interesting system, because if you just have to ask questions, sometimes they can get ticked surprisingly quickly. Maybe those questions are or are not asked. So what is our current hospital culture before we start changing what we do? Well, Certainly we know that patients with dementia are perceived as difficult, and we also know that it's not documented. So in the Hospital Dementia Services study, only about half the time was the dementia documented in the note. So we're not even acknowledging when people have dementia, let alone cognitive impairment. And more importantly, that dementia comes in with it as the problem rather than actually is the admission. And that's very problematic if in fact the entire focus of a hospital admission is hospital care is the admission problem, not all the other problems. We also know that families for socialisation need to find visiting times, and if you've got cognitive impairment, sometimes your family are your only cognitive anchor, and it's very difficult if they're not around. And also, our patients are expected to mitigate their own risk. How many people have got their medication use pamphlets to the patient which says, don't forget to tell your doctor all your medications and make sure you know your medications when you go home. And we have pharmacists spending hours with patients on discharge when 30% of them have got cognitive impairment. So some of the systems we've developed are not good, and this is the subsequent outcome. These are quotes from carers and also from a ministerial dementia task force, and I just want you to note the date. This was in 1998, and we've been concerned about change in our ability to support Indigenous populations. I think 40 years is a bit long, but it did take us 20 years to move beta blockers into our guidelines post-MI after the first report that beta blockers were required post-MI. And I'm not too fussed that we're moving now to a situation where we will change our attitude. And so back into, back in 2004, we were concerned at Ballarat about the fact that we weren't identifying people with cognitive impairment. So we developed a program which at that stage had the longest title I could possibly imagine, but we called it the Dementia Care in Hospitals program in the end. But the title was important because it was an all-of-hospital education program. So it wasn't just a program about educating doctors and nurses. It was about the porters and the ward clerks and the menu clerks who are important. And it was about awareness of cognitive impairment and communication. And what we realised is that we needed a visual alert beside that. And the reasons we wanted that was we knew that cognitive impairment was common, but also cognitive impairment had no visual stigmata. So it was very like hearing and visual impairment. And we use those quite frequently in hospitals when there are no visual stigmata to remind you that the person needs extra assistance. And we also knew that we needed clinical and non-clinical staff to assist. And we developed along with that an alert over the bedside, which is called the Cognitive Impairment Identifier. And it wasn't us who developed it. This has all been developed by carers and people with dementia. So we actually did a qualitative analysis of a series of interviews with 36 people with dementia and their families about their experience in hospitals. And we asked them, look, we want to put a sign over your bed to say your brain's not working too well. And 10 years ago, that wasn't such an easy thing to do. But in fact, they said, well, that's a great idea so long as you change the organisation, so long as you do something different. It's not about labelling me, it's about you changing yourselves as an organisation. And they provided us with some very important information, and they developed this alert over the bedside, and we've been using it ever since as part of the Dementia Care in Hospitals program. So what did we get in the way of results? Time is limiting, so I won't change anything, but I did highlight the issue about change in practice in nursing staff, and this was very interesting in that about 2/3 of staff said they knew how to look after people with dementia, and yet 80% of the staff said that the program and the alert over the bedside changed their practice. And I think this is because nursing staff and others can then target their care to those who actually need it, because they finally know who's got cognitive impairment and who doesn't. Now, in the last 11 years or so, there's been quite a change in growing national awareness, and this has been a key driver to the position I find myself in now. So back in 2005, Alzheimer's Australian National Consumers Communique said we need a symbol for cognitive impairment in hospitals, and we want a standard way of people being educated. The National Dementia Framework targeted acute care for 10-15 and does again for the new framework. Dementia became a national health priority area in 2012. And in 2013, the House of Representatives Standing Committee recommended that the Cognitive Impairment Identifier become a national symbol and there be clinician nurse consultants in cognition. And along the way, we've now got the second draft of the version of the National Safety and Quality Standards. And this just briefly is the launch for that. And there's two very important people I think it should be, because I'm not the only person who has this interest.
About raising awareness first to about the potential risks of harm for dementia and delirium and people with cognitive impairment generally. We know that when they're in hospital, their care can also be excellent, but we know that harm can happen.
I think the Caring for Cognitive Impairment campaign is just fantastic. It's such an issue in our hospitals, and I think by raising the profile, it will actually improve the care that's delivered in all our hospitals across Australia.
The goal, of course, is quite simple, but the need is very great.
We really want to raise awareness of delirium, raise awareness of dementia. We have a lot of older people in our hospitals, and at 80, 1 in 4 people will have a dementia. These people are often not recognised as having cognitive impairment when they come into hospital. They're at risk of falls, of pressure injuries, of becoming sicker, of staying in hospital much longer, and indeed they have a higher chance of dying.
So the national standards now will require, assuming the draft is agreed to by all hospitals in the country, that everyone over the age of 65 be screened for cognitive impairment. And I think that's a major step forward. We're, on the other hand, trying to re-evaluate the Dementia Care in Hospitals program. We've got a grant from the Department of Health to do that. We're working with 4 partner sites, and we've got a full evaluation occurring with Deakin University as the national evaluator on cost. And the questions we're asking is, does the implementation of the program result in fewer nursing-sensitive adverse events? And also we're going to look at quality of life and improved carer perception, and also staff perceived difficulty. And most satisfying, as of yesterday, Alzheimer's National announced that they were going to support the use of the cognitive impairment identifier as a national symbol for cognitive impairment. So that came up yesterday while I was in Canberra. So at the end of the day, I don't want this to be the perception that people have. I didn't want them making a fuss of me. There are people worse off than me. I may forget some things, but I'm not stupid. Now, this is an amazing thing. If you had physical impairment and you perceived yourself as being stupid in a hospital, it would be discriminatory. We've had a situation, we have in hospitals now, where people with cognitive impairment are perceived as stupid. Hopefully, with the standards, with some awareness and with appropriate training, we won't see that anymore. Thank you very much.